To understand urinary tract pathology, we have to map the primary oncological targets from the renal cortex down to the urothelium of the bladder. Across this entire system, one cardinal symptom mandates an immediate, aggressive workup: the sudden presentation of painless hematuria. In clinical practice, any new mass discovered in the kidneys during this workup is presumed malignant until proven otherwise. The statistical reality is slightly different. In autopsy studies, up to 40% of adults are found to have tiny, benign cortical adenomas that sat silently in their kidneys for decades. But when a tumor does grow large enough to cause symptoms, its development is highly predictable. Urinary malignancies follow a strict pipeline, linking specific genetic mutations to precise, recognizable morphological phenotypes. By tracing these specific pathways from the defective chromosome to the physical cell, we can predict exactly how a tumor will behave, what it will look like under a microscope, and exactly how it will be framed in a board exam vignette. We begin with a notable exception to the malignancy role, the oncocytoma. This benign mass arises specifically from the intercalated cells lining the collecting ducts. Its development is marked by a distinct genetic profile, specifically the loss of chromosome 1 and the Y chromosome. This genetic alteration triggers a massive overproduction of mitochondria. Under a microscope, those tightly packed mitochondria cause the cytoplasm to stain a bright, granular pink, a feature pathologists refer to as eosinophilic. On a macroscopic level, this immense density of mitochondria gives the gross tumor a distinct tan or mahogany coloration. When imaged on the CT scan, it reveals its pathognomonic physical signature, a prominent central stellate, or star-shaped, scar. If a clinical vignette describes an incidental, well-circumscribed renal mass featuring a central stellate scar and intensely eosinophilic cells, the diagnosis is an oncocytoma, and you can definitively rule out malignancy. The primary threat in adult urology is renal cell carcinoma, or RCC. Originating in the tubular epithelium, it accounts for up to 85% of all kidney malignancies. In pediatric populations, the primary renal tumor is the nephroblastoma, also known as a Wilms tumor, but RCC strictly dominates in adulthood. The highest risk demographic consists of males in their 60s and 70s. Key environmental and medical risk factors include cigarette smoking, hypertension, obesity, occupational cadmium exposure, and acquired polycystic kidney disease. The majority of these cases, roughly 65%, are clear cell carcinomas. The pathogenesis of this subtype is deeply tied to von Hippel-Lindau, or VHL disease, which is inherited as an autosomal dominant trait. Clear cell pathogenesis relies on a two-hit mechanism on chromosome 3p25. One mutated VHL allele is inherited, the second lost to somatic mutation. Normally, VHL degrades hypoxia-inducible factors. When VHL is deleted, HIF accumulates, mimicking oxygen starvation and triggering massive VEGF expression. This continuous false hypoxia signal commands the body to aggressively build new blood vessels directly into the tissue, creating the highly vascularized growth environment that defines clear cell RCC. Macroscopically, these tumors present as large spherical masses. Their cut surfaces are a distinct yellow or orange color, a direct result of heavy intracellular lipid accumulation. Under the microscope, the cytoplasm of these cells appears completely empty. The rich stores of lipids and glycogen dissolve entirely during standard tissue preparation, leaving behind the namesake clear morphology. Clear cell carcinoma exhibits a highly dangerous local behavior. As it expands, the tumor invades the renal vein, growing as a solid column directly inside the vessel. This tumor thrombus can extend up the inferior vena cava and reach the right side of the heart. The classic clinical triad for this tumor is painless hematuria, flank pain, and a palpable abdominal mass. However, presenting with all three simultaneously is rare and typically indicates late-stage disease. This tumor is also hormonally active, driving extrarenal parameoplastic syndromes. Ectopic production of erythropoietin drives polycythemia, while other hormone-like substances can cause severe hypercalcemia and hypertension. The tumor's physical impact often manifests through secondary anatomical relationships. Because the left gonadal vein drains directly into the left renal vein, a proximal tumor thrombus can obstruct venous return, resulting in the sudden appearance of a left-sided varicocele. If you are presented with a 65-year-old male smoker with an elevated red blood cell count and a new left-sided varicocele, the symptoms point straight to a clear cell carcinoma driven by a chromosome 3p deletion. The second most common variant is papillary renal cell carcinoma, representing 10 to 15% of cases. Originating in the proximal tubule, it frequently presents as multifocal tumors involving both kidneys. The genetic driver here is completely different from the clear cell variant. Papillary RCC is defined by a mutation of the MET proto-oncogene on chromosome 7q. This mutation generates a very specific architecture. The tumor cells arrange themselves into finger-like papillary projections, building outward over central fibrovascular cores. Finally, chromophobe renal carcinoma accounts for about 5% of cases. Like the benign oncocytoma, it originates in the intercalated cells of the collecting ducts. Rather than a localized point mutation, chromophobe tumors are driven by extreme hypoploidy, a condition where the cell loses multiple entire chromosomes. Histologically, these cells stain darker. They feature prominent cell membranes, clear flocculent cytoplasm, and pathognomic clear zones surrounding the nucleus, known as perinuclear halos. To differentiate these efficiently, bilateral masses with fibrovascular cores indicate a 7q MET mutation. A single mass with distinct cell membranes and perinuclear halos indicates extreme hypoploidy, which accurately predicts a highly favorable clinical prognosis. Moving down the ureters to the bladder, the cellular lining shifts to urothelium. Consequently, urothelial carcinoma accounts for the vast majority of bladder malignancies. The primary exception to this is squamous cell carcinoma, which is specifically linked to chronic infection by the parasite Schistosoma hematomium in endemic regions. For urothelial carcinoma, the heavy risk factors are cigarette smoking, occupational exposure to industrial dyes and carcinogens, and prior treatment with cyclophosphamide. Invasive bladder cancer arises from two precursor pathways. The non-invasive papillary pathway grows outward into the bladder space, graded by dysplasia. Carcinoma in situ, however, is a flat lesion where malignant cells take over the full epithelium, completely destroying the normal layer. The crucial diagnostic feature of CIS is the basement membrane. Despite the severe cellular atypia above it, the basement membrane remains perfectly intact, meaning zero invasion has occurred. However, a lack of invasion does not mean the lesion is safe. If left untreated, 50 to 75% of CIS cases will progress into fully invasive cancer. An older patient with a history of industrial dye exposure presenting with painless hematuria needs a cystoscopy. If that reveals a flat erythematous lesion with full-thickness atypia but an intact basement membrane, you have confirmed a high-risk diagnosis of CIS. Across the entire spectrum of urologic pathology, visible, painless blood in the urine is the universal signal that a malignancy is actively developing. When evaluating renal masses, diagnosis relies entirely on translating genetic markers into physical traits. Every major tumor maps a specific genetic error, like a VHL deletion or a MET mutation, directly to its resulting cellular morphology, whether that yields lipid-rich clear cells or distinct fibrovascular cores. For bladder cancer, prognosis hinges on identifying the specific precursor pathway. Recognizing that flat, non-invasive CIS functions as a high-grade ticking clock dictates an immediate clinical response. Internalizing this precise translation from genotype to phenotype provides a definitive framework for bridging the gap between a molecular defect and its clinical presentation, both in the clinic and under examination.